Thank you. Thank you again for having me. It's been a lovely visit so far, and I'm excited to talk about the process of our heart valve team at the Cleveland Clinic. It's probably one of my favorite parts of my job, to deal with all of the experts and all of the people involved in our process of evaluating patients for TAVR. So first, just a little bit about our volume. In 2014, we did 234 TAVRs. About 78% of them were femoral. 22% were alternative access. The mean STS score in these patients, which obviously doesn't account for things like frailty and so forth, which I'll mention later, was around 8, so qualifying as high risk by any objective measure. We have a strong preference for the Edwards valve. We use it about 91% of the time in commercial cases, and the core valve in about 9% of the cases. Now we're using the Sapien S3 and the core valve Evolute. And we're proud of our overall mortality, which is 0.66% in the face of a predicted risk for surgical mortality of 8%. And you can see these are risk standardized mortalities according to all of being compared to all of the other programs in the United States. And we're well above the 90th percentile. So I feel like we must be doing something right. Our stroke rate is about 1.9%, which is about the 50th percentile, to be honest. The heart valve team is mandated in our country by the Centers for Medicare and Medicaid Services. It is a requirement for any TAVR program in our country, and this is defined as a multidisciplinary team of professionals and that collaborate to decide on patient care. This is also backed up by a consensus document. Also in 2012, the ACCF and AATS, the Surgical Society, that also backs this recommendation that a place that has a TAVR team should have a multidisciplinary heart team first and foremost, with expertise in valvular heart disease, etc. It's also, for some reason, it's also part of the guidelines, the European guidelines as well. So this is a worldwide sort of mandate, and my goal here is to describe the reasons for this and also how our particular team functions. So why is a team needed? This is a new era. These are complex patients and complex procedures. The decision making can be difficult, as we sort of heard a little bit about in the last presentation. These are patients that are sometimes not clear whether you should do anything, much less surgery versus TAVR. There's definitely and the clinical trials are challenging. They need people to interpret them and come to agreement as to how they want to apply them in a particular patient's case. We all know you can't be an expert in everything. You can't have simultaneously years of surgical experience to comment on whether a patient should undergo surgical AVR and also years of transcatheter experience. The imaging is technically complex, advanced cardiac and advanced echo, CT, MRI, not to mention the anesthesia component involved, the medical treatment, and the statistical analysis of clinical trials. When TAVI first came around in the United States, there had already been cooperation between cardiology and surgery. But in this case, due to the very sick patients with multiple problems, consultation as it was done previously just wasn't enough. So we were used to collaborating together, but not being integrated together as a functioning team. As I've emphasized, this is a complex problem, and complex problems require teamwork. There are some obstacles. There were some obstacles to people adopting this. One, it was just simply familiarity. It hadn't been done that way before. And in the past, in the United States and elsewhere, there had been almost a contentious relationship between cardiac surgery and interventional cardiology, especially in the PCI versus CABG era. Other obstacles, people not being willing to share, wanting to have control over the patient, own the patient, get the credit for the work, feeling threatened by each other's expertise, competing with each other for the revenue associated. Just basically human factors that make it difficult sometimes to collaborate as a team. Probably most important is the compensation system. In the past, it was compensation. You know, who gets credit monetarily for this procedure? And so if you have a competitive compensation system, that tends to work against a team approach. But with all those obstacles, it's still a foundational requirement, and so we have to move forward in that setting, and it turns out to be a synergistic and actually very fun and enjoyable process. The key players in the team, really the foundational two, are interventional cardiology and cardiac surgery. And then there's a host of players also on the team, like cardiovascular imaging, cardiac anesthesia. These are all the pieces of the puzzle. So the principles of the team are partnership, co-leadership with open communication, attempts at early conflict resolution in the meetings, which I'll talk about, making a consensus opinion of the team, using shared resources and shared credits. So around the pieces of cardiac surgery and interventional cardiology, you have the rest of the team. Around the team, you have the institution with support by geriatrics, the staff in the lab, referral network, and the institution also has to be part of the team supporting its endeavors. So the key elements of the team functions are, this is just an overview, first patient assessment, then the creation of a comprehensive plan, then the team moves itself into the procedure and works as a team, and then the post-procedural care is also team-based. So every phase from decision to discharge is managed by this team. So the way our team works is that we have weekly meetings every Monday morning. People on the team are cardiologists, the surgeons, the interventional cardiologists. We talk about the upcoming procedures and finalize details. We also discuss all of the patients that are currently undergoing evaluation for TAVR. And we review all of the key imaging in real time during the meetings so that there are no unanswered questions at the end of the meetings. Before the meetings, the patients are evaluated separately by our cardiologists and our cardiac surgeons. This obviously requires quite a lot of coordination, and these are all coordinated by our dedicated nurse coordinators. The nurse coordinators then summarize the information, and they put it in this report. This is a typical, page 6 of one of our lists to get through during our agenda. We have the surgeons and cardiologists involved. We have a brief summary of the history. The STS score is calculated for every single patient. The frailty, every patient gets a formal frailty assessment using the kind of scale mentioned previously: grip strength, gait speed, activities of daily living. So you can see them all summarized there. The echocardiography findings, any relevant labs, most prominently creatinine, and then the results of all of the imaging, the CT imaging, including the minimal luminal diameter of the iliofemoral system, and then any other miscellaneous comments. But the whole point of this is that these are complicated patients, and every one of these things has to be considered. So having it in an organized format helps us to structure our thoughts around these patients. So these meetings are where we bring all the pieces together. We talk about the eligibility for the study. Do they have some severe symptomatic AS? Or is it a low flow, low gradient patient? Do they need additional testing? We do consider whether this is a medically futile case or not, if there is a benefit of TAVR. And obviously we talk about the risk of the patient for surgery. The STS score is just the starting ground. You know, you might have an STS score of 6, but a patient severely frail. The STS score does not accurately capture their true risk for surgery. Other things not captured in the STS score are porcelain aorta, chest wall deformities, the proximity of prior bypasses to the sternum. Very severe compromised respiratory function isn't completely captured by the STS score. Severe liver disease, this is a big one that is not captured anywhere. A patient could have an STS score of 2, but a MELD of 17, not a surgical candidate. Severe pulmonary hypertension, dementia, and frailty. And as I mentioned, we do formal frailty testing on every patient. So the clinical judgment is needed to put all of these pieces together. That's where the surgeons and the interventional cardiologists put all those factors together and make a final decision about whether this patient should go to surgery or to TAVR. Additional things that we talk about is whether there's a need for additional imaging, because we're reviewing the imaging in real time, if there's a need for pre-TAVR PCI, if there's a need for balloon valvuloplasty, for instance, in a patient who has severely compromised respiratory function and concomitant aortic stenosis, trying to determine which is the causative factor in this case, or whether there's a need for other experts to get involved, hematology, oncology, etc. Once we've made the decision for TAVR, we determine the approach, and our aim is to choose the procedure with the lowest chance of complications. Options being transfemoral, transaortic, transcarotid, transsubclavian, transapical, and this really all keys in on the review of the images. So at our meetings, we have the imaging there. We review them together to make sure that everyone is on board with the plan. Once we've decided access, we decide what kind of valve we're going to use, whether we're going to use the sapien or the core valve, or whether we're going to enroll patients in a study. We're involved in a number of studies, the Portico, the Lotus trial, direct flow valves, and that decision is made in the meetings as well. Once we get to the procedure, as I always tell my patients when I'm evaluating patients for TAVR, I always say, well, you know, we make the decisions as a team and we do the procedures as a team. We all have our role in the procedures. Our procedures take place in one of our hybrid operating rooms. It's a quite large room with a biplane and many monitors. We have the surgeons, we have the anesthesiologists, we have the nurses, and we also have cath lab nurses so that they know. The nurses have to be dual trained so that if you have to open the patient, there's a team that can do that. If you have to run and get a stent, if you have to run and get a coda balloon or something like that, we have to have nurses that are facile with that as well. Again, a lot of TAVR evaluation and TAVR procedures involve keeping this group of people all together on the same page as it's going along, because as you can see, you know, there's maybe sometimes 10 or 15 people in the room. Not usually, but it can be like that. So we try to keep everyone on the same page during our procedures. On some of our monitors, we have the key information about the patient on the screen, which I'm going to show you the actual thing, but you can see that it's visible during the procedure at all times. All of the patient's key information is present. And this is just a little example that there's the height, the weight, the age, comorbidities, labs, echo results, angiogram, and then a little diagram of where the transfemoral access will be if it's a transfemoral case, any key procedural issues. Everything is just there, so at any moment you can refer to that to remind yourself about the key factors of that patient. As in any team, you have to have a clear division of labor because people can't all be giving commands at different times. There should be a team leader. They give the commands, they manage the overall organization of the case. In transfemoral cases, that's generally the interventional cardiologist. In the alternative access cases, that is the cardiac surgeon. And the roles should be identified. I mean, in our case, we work together so much, the roles are clearly known, but early on in your experience, just identifying the roles helps keep things clear. In the transfemoral procedure in the division of labor, it's usually interventional cardiology who gets access. If it's alternative access, obviously it's cardiac surgery. It does depend on the skill set of the surgeon involved or the interventional cardiologist involved. And as cross-training becomes more common, it may not be always the interventional cardiologist getting the transfemoral access. But this is how it's functioning at our institution now. When you actually cross the valve with the wire, it can be either cardiac surgery or interventional cardiology. Usually we do the balloon valvuloplasty together. And then the optimal positioning and deployment of the valve is definitely where a lot of teamwork comes in. Before we deploy the valve, everybody agrees that we like where the position is. We don't make any changes unilaterally. God forbid if there's a complication, both the interventional cardiology and CT surgery have to be involved in assessing that. Generally, vascular closure is interventional cardiology. And then a special role of the cardiac surgeon in these procedures is the considerations for hemodynamic support should cardiopulmonary bypass be required or sternotomy. We take rescue very seriously because even though it's a low frequency event, when it happens, you need to be prepared. We have a wet cardiopulmonary bypass pump under wraps ready to go at all times. And we have a rescue table ready to go also with cannulas in reach, because when these cases go south, you have to act very, very quickly, and you can't be running to find the cannulas or getting the pump or anything. All of that equals a dead patient. We looked at our early on experience of of the emergency use of cardiopulmonary bypass at our institution. This was over 5 years, and out of 303 cases, only 12 needed rescue. 5 were due to severe AI. 3, unfortunately, were due to embolization. This was in our early experience. 2 due to coronary occlusion, 2 due to bleeding. Because of our swift action and team approach, in these highly comorbid patients crashing in the procedure room, we're actually proud of a mortality of only 16%, because without that, you certainly would have, most of the patients would have not survived. Just some logistics. It is important for all members of the team to be present for most stages of the procedure, and that does involve a lot of coordination between the team member schedules. Everybody is always aware of where people where the other people on the team are. So the interventional cardiologists check our OR schedule. We check their interventional cath lab schedule so that we can all be at the same place at the same time and people aren't waiting for each other. In terms of the communication during the procedure, very, very clear communication is a must. It's a big group of people. They're complicated procedures. It's important to keep anesthesia in the loop and tell them when you're crossing the valve so they don't start treating hypotension. You have to alert everybody when you're going to start to pace the patient, rapid pace, when you're about ready to deploy. Anesthesia and intervention and imaging cardiology gets very involved in helping us to take a look at the TEE, but only really one person should give it, specifically to do with pacing, only one person should give the pacing command. So if you're doing a balloon expandable valve and you're pacing, occasionally somebody else in the room after we finish will tell someone to stop pacing. But our nurse knows that they will not stop pacing until the team leader says to stop pacing, because the results otherwise can be disastrous. Post-procedure, the team management is basically dictated by approach. In the transfemoral cases, cardiology takes the lead. In alternative access, cardiac surgery takes the lead. But in complicated cases or cases where there's been a complication, both teams will still involve themselves in the management. Another wrinkle at our institution is that late complications of TAVR from other institutions are also managed by our team. We tend to get referred patients from other institutions who've had complicated TAVRs for one reason or another and need our team to weigh in on the management of those patients. So for instance, paravalvular AI, early structural valve deterioration. All of these are also managed by our team. In summary, it's nothing more than simple communication and the coordination of a lot of information and a lot of people. It's a different approach than people are used to, but it can be really actually fun to work with a group of people that you like.
Thank you, doctor. Really, Juan, lo que dije al principio de que el segundo tema era qué tipo de approach se hacía por femoral o qué, no es cierto. Lo que se va a hablar ahora es reemplazo valvular aórtico percutáneo o quirúrgico. ¿Cuándo debe ser percutáneo o quirúrgico? Entonces, doctora Stephanie, muchas gracias.
So the next talk is about when do we weigh our decision more heavily towards surgical valves. In the United States, the treatment of severe aortic stenosis, the TAVR is approved in high risk and inoperable patients with symptomatic heart disease and judged by a heart team to be high risk for surgery, meaning an STS operative risk score greater than or equal to 8 or greater than 15% risk of mortality at 30 days. The core valve is also approved as of March 30th for valve-in-valve replacement of a failed tissue valve. The benefit of TAVR has been clearly shown in very high risk or inoperable patients. Those are clear TAVR patients. Then there's a mid-range group where there's still high risk for surgery. You can think about AVR or TAVR. And at least now, low-risk patients are still considered indicated for surgical valve replacement. It is true that selection creep is very tempting. Patients love TAVR, physicians also like TAVR, but it is not really the time to talk about intermediate risk TAVR. There are intermediate risk trials going on, SIR-TAVI and Partner 2A, but we don't have that data yet, so my talk is not going to focus on the intermediate risk patient. So like I said, the benefit of TAVR in extreme risk patients, very, very often it should be TAVR. In high-risk patients, often TAVR. Intermediate risk, the question is out. Low-risk, surgical valve. So my talk is going to focus on within the high-risk group, who is better served by surgery. And this is a moving target. This field is evolving very quickly, and as more data is obtained, the question itself may change. At our institution, even in patients, we have a mixed group of patients. About 20% of them are high risk. Surgical AVR has a mortality of 0.5%. And we feel very confident in our surgical abilities at our institution. So these numbers guide us when we're maybe considering a high risk patient. We know we can get those patients through the operation. So I'm going to talk about when TAVR is actually contraindicated, some of the technical considerations that would make you more swayed towards surgery, anatomic considerations, the presence of mixed pathologies such as coronary disease or other valvular disease, heart failure, and then a broad concept of kind of young high risk versus old high risk and what the patient's life expectancy is. But first, just a little background. Surgery has a lot of strength in the area of aortic stenosis. There's a very long history with quite well-known durabilities of the implanted valves. Mechanical valves are very durable, for instance, although fewer and fewer patients choose mechanical valves, partly because of the option of valve-in-valve TAVR, but many patients don't want to take on the additional risk of bleeding complications from Coumadin. Bioprosthetic valves have a very well-known lifespan of 10 to 12 years in younger patients and 15 to 18 years in older patients. And the actuarial freedom from reoperation with modern biological valves is 95% at 5 years, 90% at 10 years, and 70% at 15 years. Surgery is known to have a low stroke rate and a low paravalvular leak rate. So as far as durability goes, the 5-year outcomes of the PARTNER 1 trial recently came out, and there was consideration of structural valve deterioration. So at 5 years, we know that there was no structural valve deterioration in either group. This is reassuring because there were concerns early on about early structural valve deterioration in TAVRs due to potential damage to the leaflets during the crimping of the valves. Also, the potential for asymmetric expansion with suboptimum leaflet coaptations, which may subject the valve to different hemodynamic forces that would cause early structural valve deterioration. These are the theoretical risks and concerns with the long-term durability of TAVR valves. And the best we can say to patients right now is that at 5 years, we have data that it is as good as a surgical valve. One of the downsides of TAVR is the paravalvular leak rate. In the 5-year data from the PARTNER 1 trial, obviously this was during the early experience with people less savvy about aortic insufficiency, but there was a 14% rate of moderate to severe AI in the TAVR group and only a 1% paravalvular leak rate in the SAVR group, resulting in increased 5-year mortality risk in the TAVR group with a 72% risk, 72.4% risk of mortality at 5 years in the moderate or severe group. And even mild AI has been found to be associated with poor survival in TAVR. Obviously, as I mentioned, these were first-generation devices with different learning curves. But the bottom line is that you have to realize, and this is what I tell my patients, that the durability beyond 5 years is just simply unknown. It may very well equal out to be as good as a surgical valve, but we just don't know. And so this is one of the things that I keep in mind when I'm trying to decide in a high-risk patient whether I should push them to surgery or to TAVR. So back to the question, within the high-risk group of patients, who is better served by surgery? So you always wish that it can be a slam dunk. It's obvious this patient needs surgery. There's no question about it. But in reality, it's really more a question of weighing the pros and cons in an individualized fashion for each patient, like someone like Dr. Simpendorfer's talk yesterday. Some of the slam dunks are whether there's a clear contraindication to TAVR. So endocarditis obviously, TAVR is contraindicated. If a patient can't tolerate dual antiplatelet therapy for 6 months, which is our current practice, that's a contraindication. If there is pure AI with no calcification, that is a clear contraindication to Edwards valves. People have tried it in core valve. There's Canadian experience looking at their experience with 43 patients with a core valve and pure AI. The numbers are not really encouraging, with 20% requiring a second valve and about 21% having greater than 2+ AI at the conclusion of the procedure. Other technical considerations that make a surgical valve the only option are simple valve size, if it's too big of a valve, too big of an annulus, too small of an annulus. These are moving targets as various improvements and changes in the size of the existing valve occur, but basically something above 29 millimeters or less than 18 millimeters is not a TAVR candidate. Now we start to get into some more of the nuances. The coronary ostia, generally, if the coronaries are less than 10 millimeters with small sinuses and very bulky valve calcification, those would be your highest risk patients. If there's a very severe risk of coronary occlusion with TAVR, then those patients will go to SAVR. But this is another time where the heart team comes into place because it's a technical determination, looking at the imaging and looking at the size of the valve, size of the sinuses, and so forth. These are considerations handled by the heart team and everybody on it. Bicuspid aortic valve is a little bit controversial. Bicuspid valve patients have been excluded from the major TAVR trials so that there is limited clinical experience with these patients who have elliptical annuli. The concerns, as I mentioned, in the bicuspid aortic valve are an elliptical annulus that can very easily impair the positioning and the sealing of the valve. The valves in bicuspid valves are asymmetric, very heavily calcified, and that can impede the valve expansion. And a very important one is the presence of concomitant aortic disease in these patients. The type of the weaker ascending aortas in these patients does increase the risk of dissection or rupture during any stage of the TAVR procedure, during the valvuloplasty, post-dilation, balloon expandable valve implantation. And then there are additional concerns of perhaps if the valve is underexpanded or it remains in an elliptical shape, that may affect the long-term durability of the valve. It's important to remember that we all think about people with bicuspid aortic valve disease coming to you when they're 65%, but in fact, in cadaver studies, it's present in up to 22% of 80-year-olds and 18% in 90 and above. So as I mentioned, the other concern in the bicuspid aortic valve is the aortopathy, which is present in up to 50% of the patients. The aortic media is abnormal. Certainly if the patient has an ascending aorta that is greater than 4.5 centimeters, that would play into your thoughts about that patient as to what kind of surgery they actually do need. This is another example of some of the results people have obtained with TAVR in bicuspid aortic valve. This was a retrospective evaluation in 12 European and Canadian centers. And in those patients, there was greater than 28.4% overall of greater than 2+ AI at the conclusion of their cases. 20% in the balloon expandable valves that they used, and 32% in the self-expanding valves. This data was analyzed, and it turned out that in the patients who had their annulus sized by CT, the leak rate was less, which was 17%, but that's still way higher than you would expect, for instance, in the PARTNER 1A trial of 12.2% and the pivotal core valve trial of 9%. So the bottom line being that when you treat a bicuspid aortic valve, you have a higher rate, you have a higher risk of ending up with significant AI at the conclusion of your case. As far as other considerations that weigh in when you're trying to decide whether you're going to do TAVR or surgical valves, concomitant valve disease is also a consideration. It is very common for patients to have significant MR and also AS, about 20% of that population. And it does improve often with TAVR. About 50% of the patients, especially patients who have functional MR as opposed to degenerative MR, but it does remain a risk factor, an independent predictor of midterm mortality after TAVR if you are left with moderate to severe MR at the conclusion of the case. At the same time, if this is something that's swaying you towards surgical valve replacement, you have to weigh that against the risk of double valve surgery, which has an increased risk of death. But the decision really does rest, in the case of mitral regurgitation, on the severity and the etiology of the mitral regurgitation. Degenerative MR is less likely to improve after simple aortic valve replacement via TAVR. Functional MR is more likely to improve. One consideration that you can think of is whether you're going to do a TAVR and then a mitral clip, for instance, in a degenerative patient, or if you're going to take the risk and do the double valve surgery. Other concomitant pathologies are sort of the same story. If the patient has concomitant aortic coronary artery disease, you have to consider whether it's more amenable to PCI versus surgery. You have to weigh in all of the other risk factors of the patient, the diabetes, age, etc., to decide whether the coronary disease is going to be enough to sway you to surgery or not. Again, it's the importance of everybody on the team weighing in on these patients and making a uniform consensus as to the right approach. And then last is something that I consider when I'm thinking about whether this patient would be better served by surgery. Are they a young high-risk patient who's likely to have a life expectancy greater than 5 years? Or are they kind of an older high-risk patient whose life expectancy doesn't look like it's going to be much longer than 5 to 8 years? The longer the life, at least in my thoughts, the longer the patient's life expectancy, the more heavily I have to weigh the surgical option. This is because, as I mentioned, the durability of these valves is unknown past 5 years. And it's just, you can't say to a 50-year-old, okay, you're going to have a TAVR now, and then in 10 years you're going to have another TAVR valve and valve, and then another 10 years you're going to have another TAVR valve and valve. I mean, there's only so many times you can do valves and valves. So in the younger patient who has a long life expectancy, I like to very heavily consider the fact that if I put in a surgical valve, then 10, 15, 20 years later, then they have a very good valve and valve option. Also, and the same goes for the other significant pathologies. The longer this person is living, the more heavily I need to weigh residual MR, the more heavily I need to weigh the treatment of their coronary disease, because they will have a longer-term impact of these lesions. And then lastly, I just want to mention a case. This is a case that cases like this sometimes come up at our institution, and this is the consideration of TAVR in the end-stage heart failure patient. This was a consult that I received about a month or two ago. He was a 62-year-old man with a history of rheumatic heart disease. He had had a history of mitral valve replacement in the past, now had severe AS and an EF of 15%. Definitely very high risk. But you wonder if this patient should go to VAD later, and if you say that, oh yeah, he's very high risk, we'll put in a TAVR and everything will be fine, maybe he'll get a VAD in a couple of years and this will get him through. You do have to consider the fact that when a patient has a VAD in place, there is no ejection, and the effect of continuous suction on the aortic valve is unknown. And unlike a normal human heart, which is beating and can tolerate a little AI, in a continuous flow device like this, you cannot have any aortic insufficiency. And so that needs to be weighed in. And this patient actually got fast-tracked and was considered for heart transplant. Yeah, I'm done. So basically, clearly, surgery is only best when it's the only technically available option, but generally it's a question of balance.